All right. Good afternoon, everyone. Welcome to the Mood and Motivation and Anxiety webinar by Dr. Fidel Villa Rodriquez. Following this presentation, we will have a key question and answer panel where you could ask the presenter questions. My name is Kelly, and I'm the Education and Support Services Coordinator, and I will be moderating the webinar for today. So before I pass it on to Dr. Rodriguez, I have a few housekeeping things that I would like to go through. First off, I want to let you know that we are recording this webinar um, along with the presentation slide that will be available on our website. And secondly, you will see the chat icon at the bottom of your screen. If you click on that icon, the webinar will open up, and feel free to use this chat box during the webinar to make any comments or questions for our speaker today. And finally, to optimize your experience with this webinar, please ensure that you adjust your speaker volume, both on your computer as well as your actual speaker, so that you could hear the webinar well. And if you are experiencing audio issue, please ensure that you haven't pressed your mute button on your keyboard. And now I will pass it on to Dr. Rodriguez.
Thank you so much. It's good afternoon, everybody. It's great to be back to these sessions. I believe it's the maybe the third or fourth time over the years that I've had an opportunity to engage with people through these webinars, and they're always a great opportunity to kind of reach out and have great discussions about a topic that I'm very passionate about. I'm going to start sharing my screen now so that you can see the slides. And here they are. The topic for today is mood, motivation, and anxiety in Parkinson's disease. And I should start by kind of introducing myself a little bit. I'm a practicing psychiatrist at the University of British Columbia here in Vancouver, and I wear kind of several hats. One of them is as a practicing psychiatrist. Another one is as a researcher in the Department of Psychiatry, where we do research on non-invasive neurostimulation therapies for neuropsychiatric disorders. And Parkinson's disease has been a long-lasting interest of mine since my time during residency in psychiatry. And I joined the movement disorders clinic here at UBC, I believe 2015, where I still nowadays provide consultation for people who are referred, who might be struggling with psychiatric symptoms in the context of their Parkinson's disease. And what I'm going to be sharing with you today, many of the things are actually stuff that I've learned from people that I've looked after. So I'm hoping that I don't kind of take too much time with the slides, and that I leave enough time for discussion and to engage in questions with all of you. These are my disclosures. I don't have any major conflict of interest with any, certainly with no manufacturers of medications for Parkinson's, and the lab has received funding from a number of funding agencies, and the lab has also received equipment in kind for clinical trials and for investigator-initiated research. If any have any questions, I'm happy to discuss them further. And the goals for today include three key ideas. I want to start a discussion and introduce the idea of Parkinson's disease as a brain network disease. And I'll touch on this in a second and what I mean by that. That type of framework will help us understand, I think, a lot better how psychiatric symptoms can emerge in the context of Parkinson's disease. And so we'll be discussing something that comes up a lot in clinic. It's the pondering to what extent symptoms that people are experiencing are just part of an adjustment situation to a very serious and life-changing diagnosis as Parkinson's disease, or whether those symptoms are kind of showing the emergence of an additional illness with Parkinson's disease. So we'll talk about that difference between adjustment versus depressive or anxiety disorders. Last but not least, I'd like to bring up something that also comes up a lot in clinic and in discussions, and is some psychoeducation and some reflections around the effects of medications to treat depression and anxiety, and how these are different from medications for Parkinson's. So let's dive in, and let's start by presenting a slide that in some form or shape, most of you are likely to have seen before. And what we see here, and let's see if I see my marker, is a cross-section of brain at the area of the substantia nigra. And what we can see is that the pigment that usually it's there in the area where a lot of the dopaminergic neurons are located, in Parkinson's disease, there's a loss of those cells, and then we lose that pigment and that coloration. So this understanding of Parkinson's as a focalized illness is how we started kind of thinking of Parkinson's. When I went to medical school, it was very much like, all right, we have a very defined, well-defined pathology in a concrete area of the brain. And because the cells in this region of the substantia nigra form circuits with areas of the basal ganglia, the striatum, the thalamus, where the motor circuit is completed, the symptoms that emerge are obviously motor symptoms: tremor, rigidity, decreased amount of movement or bradycardia. This was and has been for a long time the more focalized and the simple circuit perspective of Parkinson's. But in the last kind of couple of decades, maybe, there's been an increasing awareness of the fact that people who struggle with Parkinson's, most of the time, the majority of the times, also experience symptoms beyond motor symptoms. How is that possible? And in this slide, it's really busy, but what I present, and you have the references on the slides if you want to read more about any of the material that I'm presenting. What I present here is what is known as the non-motor syndrome in Parkinson's disease. So we talk about motor syndrome as the classic manifestations that affect the motor circuits, and the non-motor are a constellation of different symptoms that can affect from fatigue, which is a very common one, pain, another very common symptom, also depression, anxiety, or even in a smaller proportion of people, hallucinations or difficulties with attention, memory, what we call cognitive abilities. And what you see in this slide is roughly what is the area of the brain that have been involved in the generation or associated with these symptoms. And the key message, one of the key messages of this slide is number one, Parkinson's disease, the core features are definitely motor symptoms, but it goes beyond that. There are a lot more symptoms that cause a lot of suffering and that affect quality of life. And the areas of the brain that are involved in the generation of those symptoms are not just localized at the level of the substantia nigra. So the idea here is that even though the illness might start and might have a really focal and concrete area of the brain where there's pathology, that leads to a network affecting other brain circuits and leading to symptoms that go beyond motor symptoms. This idea of a network-based understanding of the illness is something that is emerging over the last 5-10 years, and it kind of does provide a good framework and an understanding of how additional symptoms beyond motor symptoms can present and can be a really important part of the illness. In this slide, what I show is that when we lose cells that are dopaminergic, that release and modulate dopamine levels, for sure we're going to have motor symptoms. That's going to be one of the main circuits. But dopamine and other neurotransmitters are also involved in other functions in the brain. And this is maybe a busy slide, but I think the message that what you have on this left-hand side are a number of symptoms that are non-motor. So they belong to that non-motor syndrome. And what you can see is what are the brain areas that are involved in generating those symptoms. And on the right side, actually dopamine and other neurotransmitters are involved. So I think this slide also in a form of a list brings home that key message, right? That it's not only the substantia nigra, it's many other parts of the brain that through this network understanding are also affected and lead to symptoms, other symptoms in addition to the motor symptoms. So I find this is a really key concept because it helps really understand and bring home when I see people in clinic that a very concrete and focalized pathology eventually can lead to other symptoms. And a key message is that it's the Parkinson's itself that can manifest with other symptoms rather than having separate illnesses at the same time. So a very robust way of understanding this is like there's this single illness, Parkinson's disease, that affects dopaminergic neurons, but over time, as it progresses, it starts to affect other parts of the brain. But the root cause continues to be Parkinson's. That's really powerful because it provides a really good framework to understand how such a variety of different symptoms can present in this condition. People who struggle with Parkinson's know this by heart. By the time they are referred and see a physician that makes the diagnosis, the formal diagnosis of Parkinson's, the illness has been kind of brewing for some time. And once the diagnosis is made, when we look back in hindsight, we go like, yeah, I remember, I noticed a number of different things. And here, what we can see here in this dashed line is usually when the diagnosis is made. And there's a period of time that varies from person to person where some symptoms start to emerge. And that's because as we lose more dopamine neurons, it's more likely eventually to present with motor symptoms. But before that, symptoms like losing olfaction, like the sense of smell, abnormalities in bowel movements like constipation, increased fatigue, pain, those symptoms can be sometimes subtle, sometimes more marked, but oftentimes are present way before the kind of overt and clear motor manifestations emerge for a number of years. And that's because, again, the idea is, yeah, the pathology starts in the substantia nigra. We start losing, the brain loses dopaminergic neurons, and that necessarily has a network effect on other parts of the brain, generates symptoms. And when we lose a critical mass of those dopaminergic neurons, then symptoms, the motor, which is the curve here in red, starts to emerge. And then the no motor become also more obvious over time. I think folks who've struggled with Parkinson's probably can relate to this a lot, and I would kind of look forward to hear what your experience has been. But again, this fits into that idea of a network effect and symptoms beyond motor symptoms. Now, the title of the slide and one of the topics that I wanted to bring up is, well, what is the difference between what we call an adjustment disorder versus a depression or an anxiety disorder? Parkinson's disease, like other medical conditions, is a major and life-changing event and diagnosis. Oftentimes, the diagnosis comes later in life, in our 60s, and up leading to that point, most people have developed their full potential, so to speak. That doesn't happen in many primary psychiatric conditions. For example, in schizophrenia, the onset of the illness and in major depressive disorder tends to be early on in life and tends to have an impact in life earlier on. And many times it gets in the way of developing the person's full potential. In Parkinson's is usually different, what I've seen in clinic and when is reported in the literature. It comes like a very unwelcome guest, unexpected. Is like nobody plans their retirement thinking that something like this can come their way. And it changes everything. Life has been going all right up to that point, and all of a sudden, boom. Such a major and transcendental event has necessarily an impact on any person. And if in the context of receiving such a life-changing diagnosis, the person experiences some anxiety symptoms, some kind of difficulties with sleep, or they are kind of feeling down or sad, that can be considered a reaction that is understandable to such a life-changing diagnosis. And if those symptoms persist for a little bit, like a few weeks, a couple of months, around the time that the person receives the diagnosis, but then they go away, then we call that one of the diagnoses that we manage in that situation is an adjustment disorder. And an adjustment disorder is that reaction to a life-changing event, to something that impacts our life a great deal, and that can present with a variety of different symptoms. Could be anxiety, could be sleep, could be mood. That's different from the situation where symptoms persist, linger longer over time, and reach a level of severity that they take a life of its own and an impact on quality of life and functioning of its own. That situation is where we start talking about a disorder in itself. If the predominant presentation in terms of non-motor symptoms are mood symptoms with sleep, with appetite, with decreased level of enjoyment, we make a diagnosis of major depressive disorder. If the predominant manifestation and symptoms are anxiety, then a diagnosis of an anxiety disorder can be made. As you can appreciate, in situations where there's a bit of boundary, so that the severity is kind of in between those two areas, or when the person is at the 2-month mark or a 3-month mark, determining which one of those two is can be challenging. And it might require time to figure out and to really establish the diagnosis. But overall, you can make that distinction. Again, in psychiatry, we face the challenge that we don't have specific tests, additional tests that can tell us whether it's one or the other. And so we rely on observation of symptoms and how things evolve over time. So that's a challenge that we face, and it's no different in the context of Parkinson's. So this topic of adjustment versus a mood or an anxiety disorder comes up a lot, and sometimes can be challenging at the beginning when things are merging, but most of the time, after a little bit, we can tease out whether it's one or the other. Depression as a disorder in the context of Parkinson's is extremely frequent. And so the research shows that an estimate that around 50% of people with Parkinson's will experience significant depressive symptoms. And the estimates are around 20% will meet those criteria that I was talking about, severity and duration, to meet the criteria for a diagnosis of depression. Anxiety is no different, and the rates are also very high, around 30%. Now, a situation that comes up in clinic oftentimes is the situation where, for some people, these type of symptoms of mood and anxiety only come up around or after the diagnosis of Parkinson's, meaning that people in their 20s, in their 30s, before any of the symptoms of Parkinson's emerged, were not present. There are other people that it's the opposite. They say, no, look, I struggle with depression or with anxiety in my 20s, way before any hint of Parkinson's disease would appear. We need to do a lot more research to distinguish those two. But the intuition and what the research is pointing out is there might be two different situations there. There might be a group of people who just happen to have two different illnesses. Early on in life, they develop a psychiatric disorder, a depressive disorder, a primary anxiety disorder. And later on in life, double hit, they develop Parkinson's disease. Now, this is a situation where, very unfortunate, you develop two illnesses. That can happen. It's not rare to develop two different illnesses. Then whether there's a link in the primary depression leading to Parkinson's, that link doesn't seem to be a strong, super strong link. There are other risk factors that have been associated with causing Parkinson's. So there's not a lot of data showing that having a primary depressive disorder or an anxiety disorder can cause later on Parkinson's. There's such a link for Alzheimer's, but not as strong for Parkinson's. So it would seem that they are separate. The other scenario is symptoms of depression and anxiety were never present, and they only appear around the time when the diagnosis is made or shortly before. In that situation, that gives us a stronger sense that those symptoms are primarily and strongly related to the Parkinson's pathology itself. So it's not that the person develops two illnesses. It's one, it's Parkinson's, but Parkinson's, we just learned, that can present with depressive symptoms or anxiety symptoms. And those can reach an intensity where we also make a formal diagnosis as well. Again, I'm presenting this in a didactic way where I'm presenting as it's extremely easy, but it can be challenging sometimes to tease out. But many times we have a clear sense of this. And concluding, I'd like to bring up another topic before we move on to and we open the floor for questions. Is the aspect of medications for these symptoms. How do these treatments work for depression and anxiety? And I have learned in clinic and listening to people and their experience that in the context of Parkinson's, there's an extra challenge when I prescribe medications to treat depression and anxiety, because the medications for the motor symptoms of Parkinson's have a very immediate effect. The person is experiencing tremors or difficulties with gait, and you take the Parkinson's medication, the majority of times it works, and within a few minutes, you notice an effect. So that helps people establishing that link, that cause effect, right? I take the medication, and before taking the medication, I'm shaking. And minutes after taking the medication, the shakes go down or resolve. That helps a lot. The medications for depression and anxiety don't work that way. You take the medication and you don't feel anything right away. And many times, and the same way that it happens in primary depression and anxiety, it takes a little bit of time, meaning weeks, to start noticing. And the other challenge is that the symptoms of anxiety and depression many times also fluctuate with the symptoms of Parkinson within the day. And so it becomes extra challenging to gauge, what is this medication doing? Is it helping or not? And that's a process that in clinic we go over all the time to learn how to gauge whether medications are working or not for anxiety. And that involves learning, first of all, that they don't have, most of the medications for depression and anxiety do not have an immediate effect, and that to really gauge whether they are helping or not, we do need a period of time, and we need to give ourselves a month, 8 weeks, and to look overall at what is the trend, knowing that every day can be different and kind of stressors can come our way, and symptoms of Parkinson's and anxiety might fluctuate. But are we seeing a fluctuation where the symptoms are going up and down, but trending overall down, or are fluctuating and they're overall staying the same? That's the key to gauge whether the medications are helping. And I believe I've reached the point where I stop sharing slides and we open it up for questions. So, okay. First question is, what medication is more effective? So I'm going to do a little bit of interpretation, and I'm going to first talk about symptoms of mood. And the first line of medications to treat mood symptoms in the context of Parkinson's is actually similar medications that we use for depression. And so these are called serotonin selective reuptake inhibitors. So we increase the levels of serotonin in the brain, so to speak. So medications like citalopram, sertraline, fluoxetine, all those medications are kind of the first line. And the research does not seem to favor one in particular. So, which is a little bit what happens in the context of primary depression. So it's a matter of choosing a medication that has less chances of interacting with other medications that the person is taking, and that minimizes the chances of side effects. And so the answer to the question for depressive symptoms would be the regular medications for depression. And these medications also happen to be medications that help with anxiety. And so we have, with the same medication, a potential benefit on both areas. One type of medication I should mention for anxiety, that it's called benzodiazepine, is a medication that can be very helpful in the short term. And the benzodiazepines, similar to the immediate effects of Parkinson's medications, are medications that when you are experiencing, for example, a very intense bout of anxiety symptoms, you take them, and within minutes, you can notice an effect. So that is really powerful. And they're medications that are very helpful in the short term and to treat those symptoms of anxiety in the short run. But in the long run, what happens with those medications is that have a risk of generating dependence, meaning that we need to slowly increase the dose over time to get the same effect. And those medications have also been associated with increased risk of falls if taken in the long run. So that's why benzodiazepines usually are not the first go and not the preferred medication for anxiety in the long run. If we have to use them and it just is the only thing that helps, it's okay. And we also use them to treat anxiety disorders in some people when, it's the only thing that helps someone in improving their condition. We've tried a number of other things, but the message is we don't want to kind of use them as a default or as the go-to by default in the long run. So that was the first question. Second question, is there a link between depression and anxiety and the eventual onset of other symptoms like hallucinations? Excellent question. And the short answer is, for anxiety and depressive symptoms, no, there is not that link, but there are other hints that have been associated with the chances of hallucinations. And those are sleep disturbances, particularly the behavioral sleep disturbances. So when dreams are enacted, when there's during sleep symptoms of restless legs and abnormalities during sleep, the research shows that pattern of symptoms has been associated with later onset of hallucinations. And the other one is cognitive decline. So increasing difficulties to pay attention, remember all those cognitive abilities. Those two are the two that have been most strongly linked to later development of hallucinations. And I should mention as well that hallucinations are also sometimes strongly linked to the dose of levodopa, so the Cinemet. Sometimes there's need to slowly increase the dose of medications to bring up the levels of dopamine to treat symptoms. And sometimes that balance gets a bit off. And yes, we are treating the motor symptoms, but that can be associated particularly with visual hallucinations, which is something that it's also worth mentioning. In the context of Parkinson's, if hallucinations appear, which are formally defined as there is a perception without sensory input, tend to be visual, as opposed to what we see in other psychiatric conditions like schizophrenia, where the most common type of hallucinations is auditory. It's sounds or voices. In the context of Parkinson's and medications with levodopa, they tend to be visual. So I think that's also very important to bring up in relation to that question. The next question reads, how do you diagnose anxiety disorder? What signs and symptoms do you look for? Excellent question. And I think it has two parts. One is, as I mentioned earlier, we don't have a specific test, right, that gives us a diagnosis. So what we rely on is careful kind of learning about different symptoms and how they present. And anxiety disorders are characterized at the core as a level of fear to something that is out of proportion, right? One of the things that trigger that fear and that anxiety in the context of Parkinson's is the level of uncertainty. So whenever there are unexpected things that kind of come the person's way, that kind of can trigger that sense of anxiety. Oh, I was not prepared for this. Like, and it can be something very ordinary, like, oh, I wasn't expecting this person to call me or to visit, or this appointment. I didn't remember that I had this appointment today. Things that, again, to anyone, they can trigger a little bit of a sense of nervousness. But in the context of Parkinson's and anxiety disorder, they get out of proportion to a point that they have an impact on functioning. And that's the hallmark of making the diagnosis. A lot of the things that we experience, like sadness, nervousness, many times are within the realm of what all humans we experience, right? Is when those things reach a level that get in the way, that seem to have a life of its own, and they present with other things on top of that, it's when we make the diagnosis. Other things that we look for in terms of signs and symptoms is whether there are intense bouts of anxiety. We call those panic attacks, when all of the sudden can be triggered by an event or something that triggers the anxiety, or can be unprovoked and come out of the blue. And they present with very intense sense of anxiety, sense of impending doom, kind of feelings that may sometimes heart is racing, hands can get sweaty, can feel a pit on the stomach. There's a link between anxiety and tremor in primary anxiety and in Parkinson's as well. So those are the signs and symptoms and the key features that we'll look for to make a diagnosis. The next question is, what does a DAT scan tell you? And my understanding is that that is a tool that is used in the context of Parkinson's and it's an imaging test, right? You get an image of the brain, and it allows you to gauge how the dopamine system is working. You make me think, and I think I'll have homework. I'll double check and I'll look up and see if there have been studies looking at the findings on that scan and linking them to psychiatric symptoms of whether mood or anxiety. At the moment, I have to admit that I don't know the answer to that, but I've got homework. The next question is about side effects. really important, right? With any intervention, with medication, psychotherapy, or any type of medication, we are in a balancing act. We want to get the benefits from the medication, but we know that there's also a chance of potential risks of side effects. And for antidepressant medications, the most common side effects are usually transient, so they don't last very long, and usually the body adapts to those, and can be headaches, upset stomach, changes in bowel movements, either diarrhea or constipation, but those tend to adjust. There's one particular side effect associated with most antidepressants, that is sexual dysfunction. So that means decrease, particularly of libido, or the sexual drive, the desire. That's a bothersome as well as frequent with many of the antidepressants. There are, and that's, for example, when the earlier question was asking, well, how do you decide which antidepressant to use? There are antidepressants that kind of modulate the levels of serotonin and other neurotransmitters that have less risk of, for example, of sexual side effects. So if that is an area of concern, or a side effect that gets in the way and interferes, that can be factored in the decision-making process to choose the type of antidepressant. I think those are key side effects. I think I'm touching on the most frequent and important. I will also mention something that maybe we don't discuss as much, which is side effects that can be experienced when you stop the antidepressants. That's known as discontinuation syndrome. And that happens particularly when you stop medications, antidepressant medications, abruptly. So from one day to the other, just no more medication, rather, instead of slowly tapering down. That's the fix to avoid discontinuation syndrome. And discontinuation syndrome can be presented as a kind of a bounce of anxiety, sometimes pain, headaches, a number of sweat. That's another side effect. It can present that way. And the way to minimize that risk is to slowly go down in the dose of antidepressant before completely stopping it. The next question that I have here on the chat is, do depression or anxiety cause cognitive impairment? And the answer is, for depressive disorder, it's been associated with risk of cognitive impairment per se. So the illness itself, depression, can be associated with difficulties in different cognitive areas. And that's one of the risk factors in the long run that has been associated sometimes to dementia. For anxiety itself, not so much. There's no strong evidence showing a link between anxiety causing directly cognitive impairment. The next question is a more concrete and specific question about someone struggling. I'm always in pain. Are there any safe drugs that can help? And definitely, as I mentioned earlier on one of the slides, pain is one of those very frequent symptoms that present in the context of Parkinson's. And many times is a type of pain that we call it neuropathic. So it seems to be related to the aspect of the nervous system and the peripheral nervous system not working properly and triggering the sensation of pain, numbness, pins and needles, and a number of different symptoms. The assessment and the treatments for pain are something that it's rather complex, and it does merit a very careful and nuanced discussion with your healthcare provider. So I would encourage those discussions because they're very nuanced, and it's really important to have that discussion specifically. Another very concrete question about someone in their 80, who's 87 years old, who's struggling with hallucinations, memory loss, a lot of detail about when they happened, occasionally immediately after waking up. Okay, yeah, it sounds a complex presentation. Again, these concrete questions where it's about a specific kind of presentation are better dealt with the healthcare provider, because they are very nuanced, and it's very challenging for me, and I should not provide concrete medical advice for concrete situations. What I can go back to refer is the idea that it seems that in this concrete case, that aspect of the relationship between the cognitive impairment and hallucination seems to be present. So again, that speaks to that factor. And to comment in general terms as well about one aspect that it's in the question is sometimes the visual hallucinations don't seem to be bothersome, and so that's another aspect in terms of the severity of the hallucinations. Sometimes in the context of Parkinson's, those perceptual disturbances are there, but don't seem to cause a lot of suffering to the person. Other times they do, and so what that does is speaks to the level of severity. Question here or comment, they say, I have been on antidepressant that caused Parkinsonism. There are medications that definitely are linked to symptoms of Parkinson, which are called Parkinsonism. The best example of those are actually medications to treat psychosis, because many times medications to treat psychosis block dopamine receptors. So you treat the psychosis, but you can generate and you can trigger Parkinsonism. There are some antidepressants that have been in a small proportion also associated at higher doses and long term to Parkinsonism. And yeah, that's something to discuss as well. All right, let's see. Next question. I've had Parkinson's for 18 years and on duodopa for 2 years. I have depression, anxiety, and apathy. So different symptoms, doing nothing, pain, lack of energy, not enjoying going outside. Have I reached the end of treatment options? Certainly not. That I can answer in general. There are a number of medications and also non-medication treatments that can address situations that where the person is experiencing depression. One of those treatments that specifically in the Parkinson's community is not very well known is actually called electroconvulsive therapy. And this has a lot of stigma associated with it because people my age and older, we've watched One Flew Over Cuckoo's Nest, and ECT has been portrayed through a negative lenses many times, but it's actually the most effective treatment for severe depression. And in the context of Parkinson's, there are a lot of data that show that not only ECT can help with symptoms of depression and psychosis, but many times as well, they can help with some of the motor symptoms. So ECT is not often used in the context of Parkinson's because there's stigma, lack of kind of knowledge in the community. And the other aspect is that ECT is a treatment that we use to treat psychiatric conditions a lot. And psychiatrists are the ones who are trained on delivering ECT, but not neurologists. Thankfully, in the context of the movement disorders clinic at UBC and me being around for a number of years, I would say that every single neurologist at the clinic knows about ECT at some point or other. Most of them have had a person that has received ECT, so they do know, and we do treat people with ECT. So definitely, there are many different treatment options. There's a long list of things that can be tried before saying that we've reached the end of treatment options. Not unusual. That's one of the areas that I work all the time with, treatment-resistant conditions. So situations where the first line treatment has not helped. I see we're slowly kind of getting closer to the hour, so maybe I'll be able to address one more question before we wrap it up. And it says, being treated for anxiety depression for decades prior to PD, I'm still using the same medications. Should they have changed? This seems to be a presentation that I mentioned earlier, like someone who's had depression long before any symptoms of Parkinson's have been present. And again, without kind of providing concrete advice to this presentation, the general idea and the general concept is like with any other medical condition. If the symptoms are addressed and they are stable, there's no worsening, and a treatment is helping, let's not touch anything. If and when there are changes, symptoms worsen, or the medication is not helping with those symptoms, that is a time to think about changes. But making changes when things are working or are stable, it's very problematic, and we got to be careful. Okay, there's maybe a bit more time. There's a question: do you recommend cognitive behavioral therapy for Parkinson's patients with depression and anxiety? Certainly. I've been talking about medication treatment, but in non-medication treatments, there's not only ECT, but there's also counseling, there's also psychotherapy. Those treatments are very helpful as well. And again, many times it's a matter of preference, particularly at the very beginning when the condition is mild, whether a person prefers to go for medication or start with psychotherapy, something like cognitive behavioral therapy. Many times if we had enough access, probably everybody would benefit from a certain degree of counseling and being able to do psychotherapy, particularly. And this was a conversation that comes up often in clinic, many times in early stages of the illness, is um, is a phase where, a lot there's a lot of change, a lot of questions, a lot of uncertainty, and in that context, being able to do some counseling is probably not a bad idea for anyone. Yeah, I think I would love to stay and to address more questions. We are about to wrap it up, and as usual, it's been a pleasure kind of being presenting and interacting with folks, addressing questions and engaging. I find I learn a lot every single time that I present and that people ask questions. I learn a great deal about this, and I hope that the session was informative, that people got good information out of it, and yeah, I only wish that I had more time to address more questions. Thanks so much for the invitation and for everybody's attention.